Hello students, welcome to this session where we are going to discuss viral anterior uveitis. Anterior uveitis is the most common anatomical type of uveitis you're going to come across, and viruses are some of the most common cause of infectious anterior uveitis. So there are a couple of reasons why you should be aware of this entity. One is that the same virus can have different clinical presentations, and the same clinical presentation can be produced by different viruses. So it's very easy to misdiagnose a viral anterior uveitis, and if you treat it just with steroids, eventually the patient is going to end up with a permanent vision loss. So in this session, we are going to cover the different causes, the common causes of viral anterior uveitis, and their important clinical features. Now, there's a whole list of viruses which can cause anterior uveitis, but we are going to concentrate on the big four, namely herpes simplex, varicella zoster, cytomegalovirus, and rubella. Now, these viruses can cause certain patterns of anterior uveitis, namely granulomatous anterior uveitis, a Posner-Schlossman-like syndrome, and Fuchs uveitis syndrome. First, let's look at the uveitis, anterior uveitis caused by herpes simplex and herpes zoster because they share some common features. First is that these viruses are characterized by latency. So, they remain latent in the sensory ganglia and they reactivate, causing recurrent attacks. These patients are also very symptomatic in that they present with pain, redness, and photophobia, unlike the uveitis caused by CMV and rubella. The other important point these two viruses have in common is that the uveitis may be isolated, so you might just see an anterior uveitis, or very often the cornea is involved, giving rise to a keratouveitis. Let's look at the anterior uveitis caused by herpes simplex virus. You know there is herpes simplex 1 and herpes simplex 2. HSV1 is more often responsible for anterior uveitis, and men are affected as commonly as women, and the age is 4th to 5th decade. So like I said before, these patients are very symptomatic. They present with pain, redness, photophobia, and they can come with reduction in vision if the cornea is involved or if there is significant inflammation or vitritis. Now let's look at the signs of anterior uveitis caused by herpes simplex virus. So they generally have small to medium keratic precipitates which can be pigmented, usually central or paracentral, and more than 1/3 of these patients will have a corneal involvement, which can be an active involvement or a scar. It's very important to check for corneal sensation in these cases. The active corneal involvement can be in the form of a stromal keratitis or a endothelitis. The anterior chamber reaction is moderate, but sometimes it can be so severe as to produce a hypopara. When we look at the anterior segment changes, what very prominent is iris atrophy. You can see that here. So this might be sectoral, or sometimes it may be more diffuse, and the atrophy can lead to transillumination defects. Also, because of the severe inflammation, they tend to get synecdoche. Ocular hypertension and glaucoma were two very common features which are associated with viral infections. So about 90% of patients can have ocular hypertension. About 31% can go on to have glaucoma. Now, you might think this is just an anterior uveitis. So some of the studies have shown that you get a vitreous involvement in about 43% of cases. So it's only vitreous involvement. There is no retinocoroidal involvement. When you compare the anterior uveitis caused by herpes zoster, the patients are 10 to 20 years older when you compare it with patients who have a herpes simplex infection. So it commonly happens in the 6 to 7 decade. The anterior uveitis can happen along with the vesicular eruption, or it may be delayed by many months or sometimes even years. So it's very important that you ask for past history of herpes zoster in patients who have unilateral recurrent anterior uveitis. The one sign you need to watch out for is Hutchinson's sign, where you get a vesicular eruption on the tip, dorsum, or root of nose, like this. So they will have eruptions either on the tip of the nose, dorsum, or root of nose. And this indicates that the nasociliary nerve is involved. And this particular nerve innervates the skin of the nose, the eyelid, and it innervates the eyeball as well. So the clinical implication of this sign is that you have a much higher risk of a ocular complication. Sometimes you have uveitis without a vesicular rash, and that's called herpes zoster sign herpetate. Now let's look at the slit lamp findings in herpes zoster anterior uveitis. The keratic precipitates in this can be small, medium, or sometimes even mutton fat keratic precipitates. And just like simplex, it's not uncommon to have a corneal involvement, so which can be active or a scar. It's important again to check for corneal sensation, which might be significantly depressed in herpes zoster. You also might have epithelial involvement in the form of pseudodendrites. The other findings you need to look out for is this nummular keratitis, which is like coin-shaped subepithelial opacities. They can have interstitial keratitis, and when they have involvement like this, the keratic precipitates are usually seen in the area where the cornea is involved. Or like in this case, the corneal lesion might be scarred, and you might just have a anterior uveitis which is active. The anterior chamber reaction in herpes zoster is also moderate to severe. Sometimes you can have hypopyon. It's important to again look out for iris atrophy, which may be segmental or sectoral. And these patients can also develop cataract. As with any other viral anterior uveitis, glaucoma is a common problem in herpes zoster anterior uveitis, affecting about 15 to 43% of patients. The mechanism could be trabeculitis or peripheral anterior synecdoche. Moving on to cytomegalovirus-induced anterior uveitis. Now, we all know that cytomegalovirus causes posterior uveitis in the form of retinitis, which, until otherwise proved, happens in an immunocompromised patient and is most commonly associated with HIV. So, it can also produce an anterior uveitis, and these patients, unlike the one in posterior uveitis, they are immunocompetent. Men are affected more, and this tends to be more prevalent in the Asian countries. Now, what is unique about the anterior uveitis caused by cytomegalovirus is that it can produce any pattern of anterior uveitis. It could be acute, recurrent, or chronic. And besides corneal endothelitis, it can also cause Posner-Schlossman-like syndrome in younger patients and Fuchs uveitis syndrome in the older patients. These patients tend to have very minimal symptoms. They normally present with a gradual decrease in vision. They don't have much of pain, redness, or photophobia. The anterior chamber reaction is also very minimal. And for the same reason, they do not develop posterior synecdoche. There's no vitritis, and there are no focal lesions in the fundus in the form of retinitis in these cases. So it's purely limited to the anterior segment. So a couple of findings can help you to pinpoint a cytomegalovirus-induced anterior uveitis. The first one is a coin-shaped keratic precipitates. So here what you get is, you get clusters of keratic precipitates in a ring-like fashion. Okay, this is very characteristic of CMV infection. It can happen in acute or chronic CMV anterior uveitis. The second finding you need to look out for is this nodular endothelial lesion. Okay, you have central medium-shaped nodular lesion and it's surrounded by a translucent halo. And this can become pigmented. So these two findings, namely the coin-shaped keratic precipitates and the nodular endothelial lesions, usually point out to a cytomegalovirus anterior uveitis. The other features which you can come across is, one is iris atrophy. So unlike the herpetic ones, the atrophy tends to be diffuse or patchy. You can have transillumination defects and heterochromia. Now, a raised IOP and glaucoma very commonly associated with cytomegalovirus anterior uveitis. In the acute stage, it is caused by a trabeculitis, and the chronic stage by chronic trabecular damage. And these are usually resistant to steroids. And the pressures can go really high, as 50 millimeters of mercury. Moving on to the last virus in the list, namely the rubella virus. This has been identified as causing Fuchs uveitis syndrome, particularly in West. We know that Fuchs uveitis syndrome is generally unilateral, but in this case, in up to 14% of cases, you can see a bilateral involvement. These patients present with a gradual decrease in vision, either due to the posterior subcapsular cataract or due to the vitritis. About 1/4 of these patients can go on to develop ocular hypertension. Now we move on to the two syndromes which are related to viral anterior uveitis. One is the Posner-Schlossman syndrome, which is a unilateral, recurrent, mild uveitis with a significant intraocular pressure increase. So it's unilateral, recurrent, the inflammation is mild, and you have a disproportionate increase in the intraocular pressure. This problem usually affects men in the 3rd to 5th decade. We're going to present you with recurrent episodes of blurred vision, which is associated with colored halos around the light because of the corneal epithelial edema. When you look at the eye, there's very little to see. Actually, the signs are also very minimal. You may see a few granulomatous KP. Sometimes you may see only a single KP. There might be a corneal epithelial edema because of the sudden rise in intraocular pressure. The AC reaction is also minimal, but the IOP is usually markedly increased. Like I said, it can go up to 40s or 50s. In about 1/3 of these patients, you can have a diffuse iris atrophy. Now, two viruses have been linked to Posner-Schlossman syndrome. The first one is the cytomegalovirus, and second is the herpes simplex virus. So, if you look at the incidence of glaucoma in Posner-Schlossman syndrome, 1 in 4 is going to develop glaucoma. And the risk of developing glaucoma is higher in a patient who is cytomegalovirus positive and who has had the syndrome for more than 10 years. So, the next syndrome you're going to look at is the Fuchs uveitis syndrome. It was previously called the Fuchs heterochromic iridocyclitis. Now, this term has been discarded for two reasons. One is the heterochromia doesn't happen universally. It's very uncommon to see heterochromia in dark-eyed patients. And the second misnomer is that the inflammation is not just limited to the anterior segment. They can have vitritis. So this term has been discarded and we prefer to use the term Fuchs uveitis syndrome. Now, like Posner-Schlossman syndrome, this is also unilateral. It's a chronic low-grade inflammation affecting the anterior uvea and the vitreous, usually in the 3rd to 4th decade, but men are affected as commonly as women. A number of microorganisms have been linked to Fuchs uveitis syndrome, including viruses like rubella, cytomegalovirus, herpes simplex virus, and parasitic infection like Toxocara and Toxoplasma. So worldwide, if you look at the distribution, in the east, it has been linked to cytomegalovirus, whereas in the west, the Fuchs uveitis syndrome is linked more to rubella virus. So there is a difference according to the geographic distribution. So once again, they don't present with pain or redness. They may be asymptomatic, or they can come to you with gradual, progressive decrease in vision because of cataract. Sometimes if the vitreous is involved, they can complain of floaters. And let's look at the clinical features which will help you to identify Fuchs uveitis syndrome. The first is the keratic precipitates. So the keratic precipitates in Fuchs uveitis syndrome is very different. It's diffuse and stellate. Important to remember this. So normally when you get keratic precipitates, they are distributed in the Arles triangle, which is a base down triangle in the inferior part of the cornea. This is where you see the keratic precipitates. In Fuchs uveitis, they are all over the corneal endothelium. Okay, and this is what you mean by diffuse distribution. Second is they have fibril-like processes interlinking the keratic precipitates. Now the diffuse stellate KP is not pathognomonic or unique to Fuchs uveitis. You may see them in other herpetic viral infections, toxoplasma or even sarcoidosis, but it is a very common association of Fuchs uveitis syndrome. So you can see the diffuse distribution of the keratic precipitate in this photograph. Now let's look at some of the iris changes in Fuchs uveitis syndrome. Again, very important. So they have a diffuse iris atrophy, as you can see here. They can have iris nodules, including Coppé's nodules. Now, previously, heterochromia was thought to be one of the important clinical features in Fuchs uveitis. And the heterochromia happens because of progressive stromal atrophy. So in brown-colored eyes, the involved eye will have a lighter color. But this is not a consistent feature. And like I said, in dark-colored eyes, you don't see heterochromia. So this term has been discarded from the name of the syndrome. So here you see the typical iris changes in a dark-colored eye. This is the normal eye. Here you can see that the iris pattern is lost and you can see the moth-eaten appearance of the iris. So this is what you're going to see in Indian eyes. A posterior subcapsular cataract is a very common finding in Fuchs uveitis. It can happen in up to 90% of these patients. So it starts off as a posterior subcapsular cataract, but it's not uncommon to see Fuchs patient with a total or a mature cataract. The important thing about cataract and cataract surgery in Fuchs is that you don't need very intense pre-op treatments and you don't have to wait for 3 months of controlled inflammation. And generally, they have very good surgical outcome. So the one thing you need to watch out during cataract surgery in these cases is the Amsler sign, which is an intraoperative bleeding from the angle vessels during AC paracentesis. And this is because the fragile vessels in the angle, they bleed when there is a sudden decompression. Now, like in other viral anterior uveitis, Fuchs uveitis syndrome is also commonly associated with glaucoma, can affect 15 to 59% of patients. It's an open angle glaucoma and is usually refractory to medical therapy and often needs surgical intervention. Now, coming to the vitritis in Fuchs uveitis syndrome, this happens more with a rubella infection rather than a cytomegalovirus infection. And even if the vitreous is involved, you don't get a cystoid macular edema. And the visual acuity is usually good. But sometimes, the patient is very troubled by the vitreous floaters. You might have to go for a media clearing vitrectomy. So generally, you identify a disease by the presence of certain clinical features. But Fuchs uveitis syndrome is one of those diseases where the lack of certain clinical features should alert you to the diagnosis, like the lack of pain and redness, the lack of a severe anterior chamber reaction, the lack of posterior synechia, and the lack of cystoid macular edema or focal lesions in the presence of vitritis or vitreous opacities. So in this session, we have talked about the common viruses causing anterior uveitis and their important clinical features. I hope you have found this session useful. Thank you.